This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
DPC is everything I ever dreamed of, and it is the best career choice I've ever made. This is Dr. Esther Khatibi of New Life Direct Primary Care, and this is my DPC story.
Dr. Esther Khatibi, a family medicine physician, has a passion for obstetrics and women's health. She attended Southern Illinois University for medical school, Trinity College in Dublin, Ireland for her master's in global health, and she completed her family medicine residency and a fellowship in surgical obstetrics and women's health in Corpus Christi, Texas, where she currently works. She joined the DPC movement in July of 2020 when she opened her clinic, New Life Direct Primary Care. Welcome to the podcast, Dr. Khatibi.
Thank you. So happy to be here.
I am super stoked because today's questions are really, really highlighting the fact that you are a family medicine doctor who is practicing actively obstetrics and gynecology, including deliveries and C-sections, and obviously high-risk prenatal care. So I want to make sure that the audience knows that the line of questions is definitely going to go there, because very often we see people asking, can you do OB? Can you do deliveries in DPC? And I'm so excited for them to hear your answers.
Yes, I am very happy to be here. I love everything women's health. I love obstetrics. So bring on the questions. For those listeners who have questions afterwards, I'm always available. So just reach out to me.
Love it. And just in case I forget, I just want to point out that Dr. Khatibi will be a featured speaker at this year's DPC Summit in Minnesota. So make sure that you check out the mydpcstory.com resources page, and you can find the link to the DPC Summit that's going to happen in June of this year.
Yes, I'll be talking about gynecology and at your cervix. So excited to talk about women's health there. Hope you all can join us.
Perfect. I wanted to delve into your life pre-New Life Direct Primary Care, because one of the things that dumbfounded me was the fact that you did not have medical insurance yourself until you were in college. And so can you give us a little bit of your history as a patient without insurance and how that affected your choice to go into your Master's of Public Health and your choice into becoming a family physician?
Sure. Yeah. Kind of a funny story I'll share with you all, that I remember being I'm the youngest of 6 kids. My parents divorced when I was young, so single mom taking care of 6 kids. I'm not sure why we didn't have insurance or Medicaid or something, but I just know that we did it. And 8th grade, I was like 13 years old. We went to a church summer camp, and they had a half pipe for skateboarding, and I was into skateboarding. I wasn't good at it, but I was into it. And they had, this 9-foot half pipe. And I, being the daredevil I was at the time, I was like, everyone else was too scared. And I was like, I'm going to do it. I got this. And I get up there, and my sister was there, and she was the smarter one and said, maybe you should put a helmet on. So I put a helmet on and dropped into this half pipe and crashed terribly. And thankfully I was wearing the helmet though. And I hit the back of my head really hard. And a bunch of people came over and they're like, "Are you okay? Are you okay?" And I was like, yeah, I'm fine. And I was laughing. Most people who know me, I laugh when I'm happy, sad, scared, everything. So I was laughing. I was like, yeah, I'm fine. And then I was like, "But who are you guys?" And they were like, "Quit joking." And I was like, "No, I'm not joking. Who are you? And where am I?" And I had no idea where I was. I was like having a little panic at the moment. And my sister came over and I recognized her, but I did not recognize anybody else. And they were like, they took me to my room and they're trying to show me my stuff. And I was like, "It's not my stuff. Like, I don't know." It's kind of freaking out. And then they're like, "Okay, we're going to take you to the youth pastor and see what they say." And I just remember as we were walking there, my sister whispered in my ear and she's like, "You better not be playing because, we don't have insurance and mom's going to kill you if you end up going to the ER." And I was like, despite the situation, I was like, she's right. My mom will kill me. And being a mom now, I know my mom wouldn't have killed me, but it was the whole pressure of not having insurance and having a big bill. And so I just was like, okay, I'm fine. And I never went to the hospital, and thankfully everything turned out fine, but just that feeling. And I know so many people are in that situation where they don't have insurance, they don't know where to go, they don't know what to do. And I love to cater to those patients because I know I've been in that situation, even at a young age, just not having insurance and not knowing, like, is this something where I need to go to the hospital or I don't? Like, a lot of my patients, I'm like, just call me. If you think that you need to go to the hospital, just call me. Like, I'll tell you. So yes, not having insurance as a child and, being 13 and being worried about how much something was going to cost. So I know the adults out there, I know, people who are less fortunate have the same situation, and same thing with kids who don't have insurance. Plenty of kids out there who don't qualify for Medicaid or something. So I love to take care of those patients.
That's awesome. And I think about how we're at the quote unquote end of the pandemic and millions of people are losing health insurance that was covered during the pandemic. So it's a very timely conversation that we're talking about your history and your patient population that you love to take care of. So with that said, you also went to Dublin for a master's in public health to learn how healthcare was managed and operating in other countries. Can you tell us about your experience there and what big lessons did you take home with you?
Yeah, so I went and did that master's program actually between my third and fourth year of medical school. So it was quite a change from, doing rotations to just completely different lifestyle there. And the group that was there, because it was a program for global health, was people from all different countries. So we got to hear from all of them. And then we all had to go and do a research project in a different country. And so it's eye-opening how other people feel about American healthcare and their ideas or expectations that we have the best healthcare and everybody has healthcare here, and how we have so many options and so many medications. And to some degree that is true about having more options and medications and maybe those things, but it's still not available to everybody. And I don't know, I think sometimes they had no idea of what healthcare in America was like. And I've done healthcare in Dominican Republic, in Haiti, in Ireland, some, working with the healthcare system there. Actually in Iran, during medical school, during residency, I did a rotation in Iran with an OBGYN. So I've been able to see a lot of healthcare in different countries. And surprisingly, I would have to say that even though people think the American health system is the best, we have a long way to go. So.
Definitely agree with you there. And that's why we're here and why we see so many physicians joining this movement left and right. So let me ask you there, you are a family medicine doctor again, who practices obstetrics and gynecology. And so when you were in medical school or residency, when did you decide that was the route you were going to take?
I think probably my first year of medical school, I worked with an OBGYN, and we each had a mentor. And so my mentor was an OBGYN, and I just loved it from the beginning. And then I I kind of just, like a typical family medicine, you love everything kind of thing. I'm one of those people. So yeah, I knew I didn't want to just be an OBGYN. And I have to say the struggle was real for family medicine who do OB, because you don't really fit in this group or that group necessarily. But I did know that I think I wanted to do the family medicine route with OB rather than just be an OBGYN. And I don't know, it turned out really well for me. And I love that I do family medicine and OB. So
it is absolutely awesome. And after you graduated residency, did you do a specific fellowship, and where did you do your fellowship?
Yeah, so we have an obstetrics and women's health fellowship at the residency program that I applied to. So all of the residency programs that I applied to, I specifically looked for ones that had either high OB numbers or the possibility to do a fellowship. Part of the reason why I picked this location also, Corpus Christi, you don't get closer to a border than here probably. I think there's one other residency a little bit closer to Mexico than here. I do speak Spanish, so I knew I wanted to use it, and I wanted to work with the underserved and undocumented. So I kind of thought this was the best program to pick. I'm happy I came here. I did do the fellowship, and then I went on to become the fellowship director for the program. So I think it's a great program.
And for those people who you've piqued their interest talking about looking specifically for residencies that had an OB track attached to them, or a fellowship, what words of wisdom would you have for those people who might be looking for similar programs in the future?
Yes, I would say definitely look for a program that has obstetrics that is unopposed as far as the OB, because that can be very challenging when they have an OB residency as well. Yes, you can learn a lot from them, but for family medicine, a lot of times the people who do OB are rural, so you're going to be on your own. So it's better if you learn from family medicine OB and from OBGYNs. I think picking a program that has a fellowship tied to it is probably the best, because even being a fellowship director, we tend to pick from our own program before we go outside the program, because those people are already aware of what patients you're dealing with, what systems you're using. And nowadays, I would pick a program that has some kind of curriculum with ultrasound. So I think that would be very helpful for anybody who wants to do obstetrics, is to have that training in ultrasound. So.
And you mentioned that you were the fellowship director. So I want to ask you about, what was your life like leading up to exploring and then deciding that you were going to do DPC?
Yeah, so I worked in academics. Anybody who's been in academics knows it's a lot. I had been a teacher actually prior to medical school. So I taught ESL and GED classes, and I think it trained me well for working with residents. It's a lot of work. There's a lot of paperwork. There's a lot of politics when you deal with academic medicine. So I love the people I worked with. I love the program director, but sometimes the politics and the drama within a program can really get to you. And I felt like I was just, that feeling when you open your eyes in the morning and you're like, I don't want to go to work. And I have to say, since I've started direct primary care, I never had that feeling. And I know, I'm like, no, there's got to be even a bad day is still a great day. So I don't know. So prior to DPC, I just kept going and kept going. And even though I loved what I did, it's you don't have enough time with it. And same thing with the patient care. We have 36 residents in that residency program, and just all of the administrative responsibilities. I felt like I was getting further and further away from my patients. I started giving everybody my cell phone number because they said they couldn't get through in the office. They were on the phone for 30 minutes. Some of them were pregnant, and I was very concerned, I'm going to miss something or whatever. So everybody had my phone number. I scheduled their appointments. Talked to them after hours. I was doing direct primary care in a fee for service schedule, or practice or whatever you want to call it. So I was like, what is the point? Why don't I just go to direct primary care? I feel like I'm doing it already. And I feel like I want to be in control of my office, and I want to be in control of my life. And so I kind of just jumped, and I think I wouldn't have jumped as quickly as I did if I also worked at a family planning clinic where I did their LEAPs and I did their COPLs and those things. And somebody I worked with there she had asked about coming and working with me. And then she called and said, I'm quitting my job and I'm coming to work with you. And I'm like, oh my goodness, I'm not ready. I'm not ready. Like, I know I said I was going to open this direct primary care, but I'm not ready. I was like, give me a few weeks. And I was like, looking back, I was like, why didn't I say a few weeks? I should have said a few months. And she was like, okay, just a few weeks. And I was like, okay. And she was really good. And it was like probably the best blessing that ever happened to me, because I was kind of forced to do it quickly. But I kind of just said, okay, I'm going to give my notice. I ended up working an extra year with the program, but I worked Tuesdays and Thursdays, and then I did my practice, direct primary care, on Monday, Wednesday, Friday. So, but if she hadn't told me that she quit or that she was quitting, I think I would have probably organized everything and had it so perfectly ready, but probably would have been like 5 years later. So,
well, there's nothing like ripping off the Band-Aid. So yeah. Oh my goodness. So let me take a step back there, because you are talking about how you transitioned quickly. And I definitely want to get into that whirlwind. Mm-hmm. How early in your career did you hear about direct primary care?
So I had a resident who was actually interested in direct primary care. So shout out to Dr. Vo at First Primary Care in Houston. And she was in her third year and she kept talking to me about direct primary care. And it was funny because I'd be like, come in my office, tell me about this again. Like, I really need to hear, like, do you think it's for real? Like, does this work? And then she's like, yeah, and I'm going to go do it. And I was like, okay, you go do it. And then keep in contact with me. Let me know how it goes. And I talked to her a lot. So, and she's doing great. They're all doing great over there. And I think, yeah, it was probably like a year after she left, we decided to go to, I don't know what year that was, the direct primary care conference. So we went together and like, we were just blah, blah, blah the whole time, like direct primary care, blah, blah, blah. And I was like, that's it. Like, I'm doing this from a resident. So, and now she's killing it over in Houston. And yeah, and because of her, I was like, but it was just funny because I think she had to explain it to me several times. So it's like, so wait, how does this work? But
I love that. And, you know, for those people who have not heard the story that has been shared by Dr. Kate Snodgrass and Dr. Gitu Goyal, take a listen to those episodes, because where Dr. Tivo works is First Primary Care. And I have asked T to be on the podcast, and she will be, but I am so glad that you dropped a shout out, because I love how we are all connected in this community that's growing, but that's such a cool connection. So let me ask you again about this whirlwind. Because you had weeks and not months or years to open, how did you prioritize and get help with or get assistance with opening up your DPC?
Well, I have to say I started with 0 patients, which I know is not the typical thing people are doing now. I think there's a lot more information out there about primary care. A lot of people have shared their experiences, hopefully, so that people have ideas about how to, be a little more prepared than I was. I also was quite worried about a non-compete with my contract. So I was a little bit scared to tell my patients or have them like pre-enroll, because I thought it was going to be an issue. So I kind of was like, oh, I'm waiting. And then I was like, what was the point? I should have just told everybody anyway. But so I think I started with pretty much nothing, no patients, and kind of worked its way out. I think, I don't know, we made it. We're doing well now. So
looking back, did you start by finding a clinic space? Did you start by finding your technology that you use for your clinic? What did you start with to get the ball rolling?
For me, so I knew I wanted to do OB. So with OB, it's important to be close to your delivering place, because you can get called out of clinic, or, you might have to run and check on a patient. So there's a building attached to the hospital, and I just started walking the floors. There's 6 floors. And I was like, which office is open or somebody's not using it? And then I called and I was like, oh my goodness, I can't afford this place. It's too expensive. So then I started looking for people who had like part-time hours for the week so that I could contact them about subleasing. I contacted a few people, and then I realized there was a neonatologist who I knew from the hospital, and they don't actually use their office other than just office space. But they weren't like seeing patients. All their work is they're hospitalists. So they just see their patients in the hospital. So I was like, okay, let me go ask them. And I have never been a business person. So I like knocked on their his door and I was like, oh yeah, I want to ask you a question. There's someone else in the room. He was like, yeah, go on. And I was like, so you have some office space next door and I wanted to know if I could lease it or sublease it. And I could feel my face getting like so red, like, oh my goodness. And then he was like, yeah, that sounds like a good idea. I'll talk to my partner. And then boom, they were like, yeah, this is great. We'd love to, do this. And they gave me like, I think the first month or two free rent. So they were super nice, super kind. They don't have never said anything about how we use the office space or anything. So that was a real blessing. And then once we had the space, I think that's when I told the lady who works with me. And then she's like, okay, I'm quitting my job. And I was like, oh my goodness, no, it's not yet. We have the space, but I'm not ready. And then she's like, well, I have a few weeks or something. So I was like, oh gosh, okay, here we go.
Oh man. So when you talk about your space, can you describe for the listeners, what does your physical space look like and how do you use it today?
Sure. Yeah. So one good thing is they already had some furniture in it. Like they had some couches, a few desks, and a refrigerator, a table. So at first I told them, oh, I just need one exam room because I'm just starting. So they had 3 offices, like a break room area, a front desk area, and then one extra, and then a supply closet. And at first I was like, oh, I just need the one room. And he was like, okay, well, if you ever decide that you need the other office, just let me know, because he had a desk in there and did some stuff. So I was like, okay, no, we're fine. And so we started out with one exam room, and then one room we made into a lab. And none of these rooms are large by any means. So, and then I used one for an office, and then we just used that little like break area room. And then little by little, we kind of asked him for his office, and I turned the supply closet into my office, and we made another room. And then he had one room left, but he has some workout stuff in there for when he's on call. And we put a little desk on one side of that room. So slowly, we like creeped into all of his space, but they've been very nice about it. And it was good that it was bigger than what I had expectations for, because, just having one exam room did work for a long time, but having 2 is a lot better.
In terms of you incorporating obstetrics into your practice, can you tell us about how you went from the dream, the goal, and the intention of incorporating obstetrics into your DPC to developing, how you price out obstetrical care at your practice, or how you go about taking care of your patients who are pregnant during as well as after their pregnancy?
Mm-hmm. So it was very challenging. There's not a lot of, even within direct primary care, people doing OB, but I'm pretty sure I've reached out to everybody who does OB with direct primary care to ask them about how they did their pricing, how they did, like what services they offered. Then I did a monthly fee for them, same as like direct primary care. I don't charge any delivery fee, so it's all incorporated into the monthly fee. I do have them sign a contract, not that I enforce it or anything, and I tell them I'm not going to hire a lawyer or anything. Like if you quit, you quit. But I do tell them, even in the contract, that the only reason I'm asking them to sign that is because I schedule my family's vacation and everything around their due dates. I think that's why most people want their OB who sees them during their whole pregnancy to be the one that delivers them. So I just asked that there's kind of a mutual respect, like if I know something's coming up, or if I know I'm going to be out of town the week that they're going to deliver, I'll tell them up front, like there's a chance I may not be, the one delivering you. So, but I think, everywhere is kind of unique about what you can do, what you can't do. I had gotten an ultrasound machine from a neighbor who was moving out of their office. And he said he was opening another office, but it was going to be a while. So he actually let me keep the ultrasound machine, and it ended up being like a year, and never charged me for it at all. So I had like a free ultrasound machine. So I incorporated ultrasounds into it and then just reduced the price. So that was another benefit. And then the good thing about having ultrasound is everyone wants to see their baby, and you don't have to charge them every time if you're not having to pay for it. So that was probably one of the bonus things for that. And I think anybody who wants to do OB and DPC, having ultrasound skills is phenomenal, because that is one thing, like, and we saw it with COVID, like husbands not being allowed in. So we were able to say like, hey, anybody you want can come to your ultrasound. You can take pictures. There's a lot more leeway with rules than if they go to an imaging center.
For those people past residency, not necessarily able to go to a fellowship for obstetrics, do you have any resources or classes that you would recommend, or even devices that you would recommend for people who are looking for ultrasound for obstetrics in their own clinics?
Yeah, so AHAC, which I don't really know what it stands for, but it's AHEC. But there's a program in Houston. I did their training. It was very good. I do think if you're going to do OB and you want to do first, second, and third trimester scans, that it is important to have a better machine than maybe a handheld machine. While handheld machines are good for, finding heart tones, making sure baby's position. If you're going to charge them, then you should have the skills to look at everything, look at the ovaries, look at everything that a first trimester ultrasound has protocols for. If anybody wants those protocols, I could easily give them to them as well. But those are standard protocols for what needs to be measured and everything in it. If you're not going to do that, that's fine. But if you do, I think you need to do it right. And I do think that having a bigger machine with more capability for OB is better.
Awesome. And in your area, just because the listeners like myself might not know the Corpus Christi area, do you guys even have a lot of options when it comes to cash pay imaging? If somebody were to need NT-sono or something that was necessary, but not necessarily offered in your office?
So we do have some options for cash. It is a little bit harder, and especially, so whenever you order imaging, like let's say you want to do a BP, which is the biophysical profile, and you want to wait, that's like for the imaging center. So they're going to charge them two prices, where it's not that much more. So if you could do it, or also hours. So like if somebody says they don't feel the baby moving and it's 7:00 at night, there's no options except for the ER if you don't have an ultrasound machine. So in that regard, and then we are very close to Mexico. So I do get a lot of either undocumented or uninsured people who are scared to go to an ER because they're scared of, being sent back or whatever. So they try to avoid it as much as possible. So, having an ultrasound for those patients can be more reassuring.
In addition to ultrasound, can you touch on other pieces of equipment or materials that people should have available from a bare bones startup viewpoint if they are going to incorporate obstetrics into their DPC?
Yeah, so you're going to need a Doppler. You're going to need speculums and lights for sure. You're going to need either a nitrazine taper or the more expensive Q-tip, something to measure the fundal height. Doesn't have to be, I think last year at the DPC, they had, somebody was giving away those. Was it you or no? Or was it DPC Alliance? I don't know.
DPC Alliance, yeah.
Yeah. So I used those in my office. I was like, this is great. Always helpful to have a delivery kit in your office in case something goes wrong. So one of those little plastic things to clamp the cord, a bulb suction. So yeah.
It's so funny. I'm laughing over here because I'm an hour and a half from the hospital where I preferentially delivered at both times. And that's like the stuff that I would carry in the car. So I'm laughing. I'm like, oh, I totally had my cord clamp in my wallet. So that's awesome. And I think that it's really great that you mentioned those things, because when people are asking like, oh, what do you open your DPC office with? It's not usually around what do you open if you're going to practice obstetrics. So I really appreciate you mentioning those things. Mm-hmm. Now, in terms of you opening, you had a few weeks to open, you had found office space, but what was your opening like in terms of, you said you had 0 patients. Did you have a lot of OB patients joining on as your first patients, or did you have more family practice, non-pregnant patients join your practice first?
I think we had more non-OB patients joining us. And then I printed some flyers that said, are you pregnant without insurance? And it had a lady with a pregnant belly on it, and we had the reverse in Spanish, and we started handing those out, and then they just started coming. And then we kind of networked with, there's a pregnancy center here and an SQHC that they don't really deliver their patients, so we kind of started networking with them and giving them information, and then the patients just started coming in. So, and to tell you the truth, even though like I always focus on, Spanish speaking or undocumented. The number of patients that I have who are just the working middle class who don't have insurance and then all of a sudden get pregnant, or even people on a health share who they didn't meet their time goal before they got pregnant. So they're kind of without insurance, or I've had people who are like, oh, I have insurance and I thought I was covered, but for some reason it doesn't cover OB care. And I was like, what kind of insurance doesn't cover OB? And sure enough, it didn't cover anything. So I get a lot of people who are like just middle class who don't have insurance. They are like, we can't afford to work and have insurance and everything else. So
stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. Definitely. And you mentioned how you charge a monthly fee for OBs. How do you talk to them when they're onboarding at your practice about how does it work between your services and the hospital services?
So I do let them know that what they're charged in the hospital is not my fees, but there is a charge for the hospital part. And I went to the hospital and negotiated with them, and it was like pulling teeth to get those prices. And that was prior to that bill that came out where they're supposed to have more transparent pricing. So I don't know, maybe that will help people who are starting now, but to run into the president of the hospital in the doctor's lounge. And he said, I was like, I haven't met you. And the president, I was like, okay. And he's like, if you ever need anything, just let me know. And I was like turning to walk out the door and I was like, this is your chance. So I was like, yes, I actually need some pricing for the OBs. And he was like, okay, well, I'll put you in contact. So he put me in contact with someone, I think because it was him saying it, all of a sudden I got this pricing right away. So it was like perfect timing to be in the doctor's lounge. But I also put that in the contract. This is the price for a vaginal delivery based on a uncomplicated delivery. This is a complicated vaginal delivery, and this is the pricing. This is a C-section, and these are all based on, for a vaginal delivery, 1 night stay, a C-section, 2 night stay, and that, it is an estimate. So it could be more than that depending on what happens. But I do give it to them. And then they also gave me the pricing for if they like half of it up front or a quarter of it, then there's a certain percentage discount. If they pay half of it up front, if they pay all of it up front, there's a like 75% discount. So just to let the patients know, some of them can't do that, but just knowing that that they could be on either a payment plan or get a significant reduction if they paid more upfront. And then I also let them know that everything in the hospital will be under my name, but it's not my bill, because I've had some of them be like, well, you billed me for this and this. And I'm like, I'm the ordering physician over there. Everything goes under my name, but I am not the one billing you. So.
And what happens if there's any pathology charges or NICU charges or anesthesiology charges?
So that is left to the patient to negotiate with them. And I tell them, things that are not covered. And for our contract, it's their prenatal, postnatal care and their delivery with me. But as far as their hospital charges, and that it is to be expected that some of them will show up, 6 months, 7 months after you deliver.
And In your area, have you found organizations that will help? Because how you described you're so close to the border with Mexico, have you found organizations that will help support the needs of some of your patients if they find themselves with extra bills that they didn't expect going into labor?
Well, I have actually opened a nonprofit called mydoc.org specifically to help those patients in need for OB care and to reduce the pricing, because even though I feel like my pricing was great for the OB package, for some people, it's just not affordable. And I always wanted to have affordable and helpful. So filtering it through a nonprofit opens the door for either grants or donations from other people to kind of help provide for those patients. So that is the goal, is to, find a way to help kind of reduce their hospital costs as well. But yeah, we are in the process of working on that. If anybody who's interested in having direct primary care, OB, wants to come join me, please call me. I would love to hire another doctor to work with us. So
I just love this. I mean, you're sharing about how you were, red in the face asking for an office space. And here you are talking to the president of the hospital and negotiating prices, and you're going to get partners left and right from mentioning that on the podcast. Yes, so I love it. I absolutely love it. So good. So given that you have a space that's close to the hospital, you're doing deliveries, one thing I want to ask is, do you do VBACs at your hospital?
Yes, we do. Mm-hmm.
Awesome. Because I know that that's not always an option in centers and around my area. So definitely wanted to ask that, especially if future partners are listening and want to do VBACs as well. And also, when you mentioned that as a family medicine doctor who actively does obstetrics, that you don't necessarily have a group to hang with, the family medicine or the just OB-GYNs. When you started your DPC and you were at your hospital, have you had any pushback from your experience now as a DPC doctor delivering at the hospital where you have been for years?
Well, I think because I made the transition from academics to DPC and I was still in the same hospital, I think it was harder for me that nobody realized there was a change. They all thought I was still with the residency program. I don't know, for me, I wanted to separate myself from them, not because I had any problem with them, but I just wanted to be my own. So for me, the problem was more like, how do I separate myself from them rather than dealing with the OBs? I think the OBs were used to me, but they all thought I was with the residents. And same thing with the nursing staff, or everybody was like, oh, well, where are the residents? And I'm like, oh no, I have my own practice now. It's just me. And they were all like, what? Like, I had spent so many years training other doctors that they were always with me, or medical students, or there was always like 2-3 people in the room. So for me, it was kind of refreshing to just be myself in the room and not have any other learners. So I think I'll get back to the point. I do love teaching and I do love residents. So probably won't be long before I'm like, come with me. Like, let's learn something cool. Or I love doing ultrasound with them too. So, but yeah, I think, depending on where you work, a lot of people have issues with other OBGYNs, either call schedules or what they're able to do or not able to do. We are lucky enough to have OB hospitalists at our hospital who are very supportive of us and back us. Will attend your C-section to help assist you if you need, or will come into the room if you need help with like a vacuum or something like that, or just want a second opinion. You can run over there 24 hours. So they are all super awesome. And I don't think that's the case everywhere else, but we're very blessed to have them. And our MFM have been great too. I mean, I feel like I could call them for anything. Tend to get very complicated patients here, just the number of things, and their confidence in us. They're like, oh my goodness, you can manage this. Like, we did that one case together and they're like, you got this. But just having their support is awesome. So, and I know it's not like that everywhere. So I just have to say I'm probably super blessed here. And yeah.
Now, being a family medicine with obstetrics on board, what have you found is your best option for malpractice in the state of Texas?
There are quite a few options for malpractice in Texas. I have to say, plan on paying a lot more for your malpractice than a typical DPC, because you do have more risk and liability. So you're probably going to pay double, maybe triple what somebody else might. But I have to say this too, I am never worried about getting sued in DPC, whereas in academics, it's super scary because you don't know your patients and you feel like you can't communicate with them. And I think that's what the majority of lawsuits, especially in OB, is like nobody contacted the doctor or they, weren't aware of this. In this model, like we're aware of everything. We know you. We're the only ones who see you. And I think that's why people come to you, is because they know that you're the only one seeing them during the whole pregnancy and you're going to be the one that sees them postpartum. So I think the risk of a lawsuit is a lot less in DPC.
When you talk about DPC, very frequently we'll see, DPC doctors taking a cap on how many patients they have in the practice. So how many people do you take at one point in your practice when it comes to OB versus family medicine, non-pregnant OB patients?
I haven't really put a cap on it. I have taken breaks from OB because the call can be a lot. So sometimes a family strain, not being able to leave town, some issues with call or having a backup. So I would say there have been times where I said I'm not taking OB for a short period of time so we could go on vacation and be stress-free. But I really haven't capped a regular amount of, honestly, I have not done much marketing. I mean, I post on Facebook here and there. So I'm not actively out there, trying to get 300 more patients or something like that, or even the OBs. I mean, we hand out the flyers to those few locations. And other than that, I don't do any outreach or marketing or newspapers or radio or anything like so. So we kind of have a steady flow, but it's not too much.
It's incredible. And it shows how needed your services are in your locale. So I think that's awesome. What about your overhead? What's your overhead like in terms of separate from malpractice?
So I did hire a sonographer to help, which is great. And the good thing about it is they can be scanning and you can be watching, and then they're putting everything in. It's kind of like, what do you call those people who write your notes for you?
A scribe?
A scribe. There you go. Kind of like that. So they are, as you're seeing it and you're discussing it, they're putting everything there. So it saves time. And then also their expertise. The lady I hired is phenomenal. She's like great with patient care, and she'll be like, oh, here's their hair and here's their fingers. And she like points out everything to them, which like as a physician, you're kind of like, okay, here's a heartbeat, like your key points. And you forget sometimes that whole like, oh yeah, they're new mom and they have a baby and like they're excited. So that's been great. But that is like hiring somebody else, and then the ultrasound, I would say, and then probably that's pretty much it. And you really don't even have to offer those services. So not a lot different than a direct primary care as far as overhead. Maybe you definitely have to have an exam bed with stirrups and those kinds of things.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Haiti Health is the best AI scribe I have come across thus far. With Haiti Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Haiti Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Haiti Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Haiti Pro free, go to the homepage of mydpcstory.com and click on the Haiti Health ad. So this is a question that is coming from, you mentioned how you were in the Dominican Republic and Haiti and other countries, and even in Iran. When I was in the DR, we had very creative strategies as to like how to do pelvic examinations, because it was like anything went. I mean, gym floors, park benches, people's bedrooms that we use their beds. Have you found any ways to MacGyver, like massage tables to have stirrups added? Because this is actually coming off of a conversation that I had with Dr. Amber Beckenhauer when we were in her brand new area where she has aesthetics chairs. And we were trying to think about like, how could we weld or do something to add stirrups to an aesthetics chair, because it's sometimes cheaper than a medical chair.
Yes. Luckily, I have not had to, because funny story, someone in the building was getting rid of a exam table and they were like, but you have to come and move it. And I was like, okay, anybody who's tried to exam tables are super heavy. But my husband builds houses and he's like very smart about those things. And so I told her, okay. And she's like, she sold it to me for very cheap because she was like, somebody else wanted it, but this thing is so heavy and I can't figure out a way to move it or whatever. Well, I went in with my husband, those dollies that have like 4 wheels. He like just lifted the bed, slid that thing under, and we were gone in like 2 minutes. And she was like, what did you guys do? And how did you get it out of there? So I think I was blessed to have those beds at a very cheap price from somebody. So I haven't had to, but I'm sure there are ways, and I've used when I said that you need them for overhead, you're right. You really don't. Mostly here in America, you just feel like you need something, but you don't. But yes, in like Dominican Republic or whatever, we would turn over like Tupperware tubs and they would sit their bottom on it so that it would just lift up the pelvis kind of area. But yeah, there's all kinds of things, but I haven't had to do that yet with kind of one of those aesthetic type beds.
That's a challenge to the listeners. So come find us at the DPC Summit in June. And if somebody has a solution to that, ironically, I'm interviewing Nick Thompson in a couple of days, so I will ask him, but let us know, because that definitely could be information that somebody could use, whether they're practicing in the States or abroad. So
we can take it to Shark Tank.
Love it. Love it. You mentioned how you were providing LEAPs and colpos for a clinic that you were working at, and you continue to do that in your own practice. So in terms of having like a colposcope and procedure tools for LEAPs, did you invest in those, or how do you work those procedures into your clinic?
So some of them, the clinic that I worked at before, they offered to me because they were updating their supplies and equipment. So older versions of them, and I find I would not buy a new one if you're not going to do it all the time, because they're very expensive. And there's so many people who are updating or businesses that would love to give you their old one. I think even with the residency program, we had like 3 or 4 of them sitting there that just were not used that often. So not that hard to get the equipment. So I wouldn't invest.
Great. And in terms of your price point, how do you price out LEAPs or colpos for patients, whether they're in your practice or whether they're non-members?
Well, I include it in the cost of the membership. Pretty much most of the procedures I do are all included in the membership, other than even deliveries are for the OB membership. But
given that you are so close to the border with Mexico, when you have people coming to your practice and they're, not in a place where they're afraid to talk to you openly, do you see more serious pathologies, not only in obstetrics, like you mentioned, but also with non-obstetric related diseases? And how do you handle the severity of disease when if you see that coming through your door?
Unfortunately, Corpus Christi has a very, I would say, poor health score overall for a lot of the population here, as far as people not seeing doctors on a regular basis or having issues with obesity here is very big, or diabetes. People coming across the border tend to have similar things, but I would say some things that, and I really haven't had to deal with those as much here, but people having rhabdo or things like that because they were several days without food or water en route, or when I was with the residency program, because I did their OB, having minors who were raped along the way, or those kinds of issues, getting pregnant along the way, or, an issue of being molested and, some kind of sexual assault. And that's the reason why they're leaving their home and trying to come here. So a lot of times because they are hooked up with like an immigration center or something, they have to go through a program that has funding or takes some kind of like government insurance or whatever. But a lot of times they will try to get them with family. And then the issue is, the family doesn't have insurance for them. So, once we saw them and then they flew off to be with family, it was kind of like this, you never know what the ending was. But I always thought about it like, well, maybe the family really didn't want that financial cost or weren't that close to them. And then they're in the middle of somewhere else, even though they had family, they're in a bad financial situation, pregnant. And then the other thing was sometimes they would be asking for you to sign off for them to fly. And then I'm like, but they need to see MFM and there's no guarantee. There's no appointment set up for MFM. I don't think they're going to get in. So no, but as far as the pathology, I think it's pretty similar. I can't say that it's that different, but that may just be because I've only seen so many patients.
So Dr. Khatibi, I mentioned that you're going to be a speaker at this year's DPC Summit. I want to close with, if people are attending the DPC Summit or if they're on the fence about it, who would be the perfect audience member for your talk at the DPC Summit this year?
So anybody who's interested in women's health or even OB, even though I won't be talking about it, you're always welcome to talk to me before or after about it. I do have a passion for both of those topics. So I will be talking about different pathology of the cervix, how to manipulate to get a good pap or how to, determine whether somebody needs a colpal or those kinds of things. So yeah, I guess anybody who has doubts about doing those exams or how to treat them or just wants a few tips or secrets about how to get the best biopsy. And hopefully I'll have some things set up there to kind of simulation, like a lab. Yeah. So something to simulate collecting biopsies. And
just one more thing on that note, just because especially with the OBs that I've worked with over the years, people have lots of different apps that they recommend. Do you have any particular apps that you love, whether it be the like ASCCP app that's like $10 and totally worth it in my opinion, or other apps that you love to use every day?
So I would definitely second that ASCCP app. That thing is like gold. I use it all the time, any PAP. So for those of you that haven't used it, it's a nice way to recheck the screening guidelines to make sure you're up to date on those, as well as you can put in the PAP result findings and either the colpal findings or to determine, there's like algorithms to determine what's the next step. So it's extremely helpful. Good reminder, especially for family practice, because we do so many things. So just knowing it's there, I'm always like, okay, well, I can just double check with the app always, but it's a great resource. And CCP also offers a CME course where they do colpal training. And I went to that several years ago and it's phenomenal. It's a great opportunity if you get the chance to go and try that out.
And do you think someone who might be, a few years out of residency, do you think that colpo training is sufficient to start practicing colpo in their offices?
Yes, definitely. I mean, honestly, there's lots of nurse practitioners out there and all kinds of other people doing colpo. So if you've done a residency program, you could go to the training and you can do it. And if you need a little support, just call me.
Love it. Thank you so much, Dr. Khatibi, for joining us today. And I can't wait to see you in person at the DPC Summit this year.
Yay, I'm so excited. Thank you for having me.
Next week, look forward to hearing from Dr. Nick Thompson and Dr. Brandon Ullman of Antioch Med in Wichita, Kansas. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Concepcion.